is currently at capacity. And so we are live streaming to YouTube, and we're trying to connect with Google Meet. So please bear with us for that. Additionally, the attendance has been sent to chat. So please, everyone check that out and ensure to fill that attendance so we can all get our certificates, at least those of us who were able to make it into this meeting. With that being said, I will be leaving the floor to my co-moderator, Oluwatosin.
Just wanted a quick thing. I am just staying on the line and I'm actually responding to the questions in the Q&A directly. So some of you will go away with some responses as I have not been able to do everything. I will try to go through them and respond as much as I can.
Oh yes, thank you very much, Dorian. That works fine. So moving on, I'll be leaving the floor open to my co-moderator, Tosin, to keep us rolling. Okay, at the moment, it doesn't seem like Tosin is able to connect. We're having technical issues. Genuine apologies about that. So, in that case, we will be moving on to our next speaker, who is Oliver Rosenbauer. Oliver, please, could you connect to the call? Okay, we have Oliver trying to connect.
There is Oliver. Just maybe unmute Oliver. There you go. It works.
Hello, everyone. Can you hear me?
All good, loud and clear.
Thank you. Thank you for the invitation. My name is Oliver. I work for the Polio Eradication Department at WHO here in Geneva, and it's great to see you all online. I was asked just to give a little bit of a background or presentation about polio eradication. I have some slides that I could share. Let me try to share them and see if it works. And if not, I will speak without. So let me share. Okay, I hope that worked. I hope you can all see. So basically, as I mentioned, we work for the polio eradication department here at WHO, and maybe to remind ourselves first what polio actually is. It's caused by a virus. The symptoms are paralysis for life. If your paralysis is sufficiently severe, your respiratory muscles are paralyzed and you cannot breathe anymore. And there's no cure for polio. Once you have it for the rest of your life. But it can easily be prevented through vaccination, and that is what we're trying to do through vaccination. The vaccines were developed and have been around since the 1950s, and the disease began to disappear very, very rapidly from developed countries like North America, like Western Europe, Australia, and so forth. And we talked a lot with Doreen in the previous session, of course, about equitable access to health and is it a public good? And so what actually we looked at in the 1980s, we said, look, there's this vaccine that works. It's affordable, it's available, it's easily administered, and it's not right that children in North America have access to it or Western Europe. Children everywhere have to have access to it. And so we teamed actually up with the WHO with a number of other organizations, of course, the member states, as we have talked about, but also organizations such as Rotary International, CDC in Atlanta in the United States, UNICEF, and we were later also joined by Gavi, the Vaccine Alliance, and the Gates Foundation. And we looked at the situation, or scientists looked at the situation, and they actually came to the conclusion that polio is a disease that could be globally eradicated. Most diseases cannot be eradicated for a number of biological and technical reasons. COVID, for example, cannot be eradicated. It is technically and biologically not possible to eradicate COVID. Polio is one of the few diseases that can be eradicated, and globally, there's only ever been one disease that has been so far eradicated. That was smallpox in 1980. And so, together with these partners, and of course, all the member states, there was a decision made at the World Health Assembly, hey, let's try to eradicate polio. And this decision was taken in 1988. And this is what the world looked like in 1988 in terms of polio. There were over 125 endemic countries worldwide. Then every year, over 350,000 children were paralyzed by the disease for life. And this is what the world looks like today. We're basically down to endemic polio, two countries, Pakistan and Afghanistan. And even within those two countries, it's very geographically restricted. So polio, the disease itself has been reduced by 99%, which is great. But we're not after 99%. We're after complete eradication, and that means 100%. And the reason why that's so important to achieve 100% is illustrated very nicely on this slide. It's polio is a highly infectious disease, and it will always reemerge to cause outbreaks in countries that had already been polio free. Africa, for example, as a continent, had already been polio free about 10 years ago, but the disease reemerged. And we're again seeing outbreaks across some countries in the continent, including in northern Nigeria, including in neighboring Chad, in the Horn of Africa. Other parts of the world. 2 years ago, we had an outbreak in Gaza, which is probably the last thing populations in Gaza needed, was a polio outbreak, given everything else that was happening there or is happening there. Papua New Guinea, and it's not only in developing countries that this risk exists. This risk exists everywhere. That polio will come back. I think it was in 2021, a person in New York City was paralyzed by polio. We keep detecting the virus across European countries over the past 18 months. So that is what will continue to happen until we've managed to eradicate this disease completely. It will always reinfect countries. And Harvard Medical School, a few years ago, they did some mathematical modeling to see, okay, what would actually happen if we abandoned this effort without eradicating polio. And their modeling very clearly showed that we would go from a handful of districts in Pakistan and Afghanistan to global resurgence of this disease. And we would again see every year 200,000 children paralyzed all over the world within 10 years, every single year. So that's the risk that we're facing. And that is why WHO has declared the effort to eradicate polio to be a public health emergency of international concern, which is our highest level of alert, which means that countries which are infected by polio should take extra measures to try to stop the spread of the virus, such as exploring vaccinating international travelers, for example. So that is how serious this organization takes this effort to try to eradicate the disease. But if we look a little bit more closely at where we stand at the moment, in terms of our eradication effort, I think we have three priorities. Our first priority, very, very clearly, is to try to finish the job in Afghanistan and Pakistan. Those are the only two countries which are still endemic to wild polio virus. They are the only two countries which have never eradicated the disease. And it's from here that the virus will continue to spread out, to cause outbreaks in other areas. And in both of these countries, we're actually seeing tremendous progress being made to try to eradicate polio. We are seeing the two countries are bordering countries. They share a joint border. This border is about 2,000 kilometers long, which is about twice the length of Germany, which is where I am from. And there's a tremendous amount of population movement across this border. So as far as we're concerned, we're treating both countries as one epidemiological block. It's the same poliovirus strain that keeps getting ping-ponged back and forth across the border with population movements. And so we kind of have to take a coordinated cross-border approach to try to finish the disease. But there's really only a handful of districts on either side of the border which are really the endemic reservoirs. You see on this map on the right, those are the two countries, Pakistan in the south, Afghanistan in the north. The circles are actual cases of polio, so children who came down with paralysis in the last year. The squares are where we detected the poliovirus in sewage samples. So you can see, particularly in Pakistan, we keep detecting it in other areas of the country as well. But the virus never has a chance to establish a foothold in those areas because you have extremely high vaccination coverage. And so what we're seeing at the moment in both countries is we're seeing the geographically speaking, the most restricted situation that we've ever seen of the virus. In other words, it's geographically limited more than ever that we've seen before. And it's primarily in the cross-border area of what we call Southern Khyber Pakhtunkhwa province. And this is very much a tribal area. This is an area where the government doesn't have a lot of control. This is an area where the Taliban is very active. And so getting access to that area in order to be able to vaccinate children is very, very challenging. But nevertheless, from our perspective, polio is at the lowest levels ever in both of these two countries. So that is our number one priority, very clearly. Our second priority is very clearly we have to stop outbreaks in polio-free countries where we know there are outbreaks. For example, in Nigeria, for example, in Gaza, for example, in Papua New Guinea. To stop an outbreak, it's the same way as you stop endemic transmission. You try to vaccinate as many children as you can. Poliovirus only survives in humans, primarily in children. So if you vaccinate all children in a given area, the virus has got nowhere to hide and it dies out. So that's the objective. Excuse me. How that's done kind of depends on the geopolitical context in each area. In Gaza, the photo on the right, our primary challenge was we needed access, we needed a humanitarian pause, and it wasn't until Israel and Hamas agreed to two sets of 9-day ceasefires that we were able to implement an outbreak response. So that was the main challenge there. In Papua New Guinea, this photo on the left, the challenge is more that populations live in extremely remote areas, on islands, in highlands. There's no roads, there's no road network, there's no transportation means to get to these villages. In many areas, we have to helicopter in both vaccines and health workers. So it's reaching the remote areas that is our primary challenge. So it kind of depends on what the prevailing obstacle, if you like, is to reaching every child, and accordingly we adapt our tactical challenges. But the goal is absolutely the same every time to try to vaccinate each children. And our third priority is to protect polio-free high-risk areas. So countries that are currently polio-free, but where we consider them to be at particularly high risk of reinfection. And that's primarily countries in sub-Saharan Africa and Southeast Asia and the Middle East. So we don't just vaccinate in Pakistan and Afghanistan, but we vaccinate in about 55 countries around the world. And every year we reach about 450 million children. So that is our overall goal. I think we're in a little bit of an interesting situation at the moment because with Doreen, we talked a lot about what is the role of politics in public health. And I would say for us in polio eradication, actually, we are now almost entirely a political program. From a medical point of view, from a biological point of view, we have everything that we need in order to eradicate polio. We have the vaccines, we know how to do disease surveillance, we know how to do genetic analyses of the virus that tells us where it is, what it's doing, how it's behaving, where it's going to go next. Biologically, we have everything in place. What we sometimes lack is the ability to reach every single child. And those solutions are all geopolitical in nature. The Gaza example to me highlights this very, very clearly. When we had news that there was an outbreak in Gaza, everybody thought, well, game over. There's no way that we can do an outbreak response given everything that is happening there. But the reality was that authorities on both sides of the conflict, Israel and Hamas, looked at the situation and they decided, okay, we have a polio outbreak. We know that if we do an outbreak response, it will be very rapidly stopped. If we don't do an outbreak response, it will not stay in Gaza. It will spread to Israel. It will spread to Jerusalem. It will spread to Tel Aviv. So if we don't want that to happen, we need to do an outbreak response. And if we need to do an outbreak response, we need to have a ceasefire. And so that was a political decision to implement a ceasefire. It was not a medical decision. It was the correct decision. So in a way, it's a little bit our decision as a global society, if you like, if we want to eradicate this disease or not. If we take the correct political decisions, then we will eradicate polio. We know that from the science, we know that from epidemiological history. And if we do not take the correct decisions, then we also know what will happen. We will see this global resurgence of polio, and it will spread all over the world again, as Harvard Medical School predicted in their modeling. But if that happens, we also will need to then kind of accept the consequences of that. We won't be able to say, okay, we didn't have a vaccine or we didn't know how to do disease surveillance or anything like that. We know all that. Then it will simply be that we chose not to eradicate this disease. So it's a little bit of an interesting situation that we have at the moment. We're of course all working towards case zero when finally this disease will be eradicated. In the meantime, though, we do like to remind ourselves what has been achieved since 1988 when this all started, and there's been a lot that's been achieved. More than 22 million cases have been averted. More than 1.5 million childhood deaths have been prevented, and every year over 500,000 children are prevented polio paralysis. Among those, about 65,000 deaths would occur. So there's a lot that is being done. But again, our goal is eradication, and that has only happened one time with smallpox. And Doreen mentioned it earlier. The one of the big successes of WHO working with member states was the eradication of smallpox. And what it actually means to eradicate a disease, because there's nothing more sustainable or equitable than the eradication of a disease. All countries benefit equally from it. And if you look at smallpox, this is Ali Malin. He is the last human smallpox case on Earth. In 1977, he was infected in Somalia. He actually thankfully survived his smallpox infection, and he worked for many years for the polio program in Somalia. He used to say his country was the last on Earth with smallpox, and he didn't want it to be the last with polio as well. If you look at what happened just in the 20th century, in the 77 years before Ali contracted smallpox, Smallpox worldwide killed over 500 million people worldwide. And those are actually more deaths than were caused by all wars that have ever been fought across human history, including World War I and including World War II. But since 1977, not a single smallpox infection. No one ever got smallpox again. No one died from it. And that's something pretty incredible if you manage to achieve that with a single disease. And we have an opportunity to achieve that for only the second time in history. And that is what we are all working towards. So that's just a brief overview of what this effort is about. But maybe back over to you, facilitator, if there are any questions, I'm happy to take them. Or in any event, back over to you. And thank you again for the invitation to present to this group.
Thank you very much for your speech. I believe we've all been able to pick up a few things from Oliver's presentation, including how the WHO was able to achieve total eradication of smallpox. There are quite a number of questions in the Q&A. But because of time, we would only be able to take a few of them. So if it's not a problem, I will try to read out some in the order of where we stopped from the last time. Probably take out 5 questions, and then for the rest, we can have them documented and maybe answered tomorrow. So the next question here is from Ibrahim Abba. He asks, how can young leaders and community advocates effectively collaborate with the World Health Organization to turn global health policies into practical, measurable impact at the grassroots level, especially in countries like Nigeria?
Oliver?
Oh, is this a question for me or
Yeah,
for
yeah, for
okay.
you, for you.
Oh, sorry. Uh, I mean, for polio eradication, uh, this is very, very clear. The implementation is done at the community level. This is a community-based program. The vaccinations are done by local volunteers. In northern Nigeria, I think, when they run a polio campaign to reach, I think, 45 million children across the country, they recruit about almost 500,000 volunteers. These are people from the local community who bring the vaccine door to door. So it is not a WHO or UNICEF person who is coming to deliver the vaccine. It is the mother who lives one street over from you, who you know, who you trust. And they are the real heroes of this polio eradication effort. And it's thanks to them that that we're so close to eradicating polio, including in Nigeria, which, as mentioned, had already been polio free. It was one of the huge success stories of the global eradication effort to finish the job in Africa's most populous country. And so, without that community engagement, nothing the polio eradication would not be achievable. You have, of course, parents, mothers, and fathers who are actively engaged. You have community leaders, you have religious leaders, you have Christian leaders, you have Islamic leaders, you have school teachers, you have nomadic leaders, you have state governors, emirs, of course, the Ministry of Health. And this is really an all-out government approach, mobilizing all sectors of civil society to try to yes, to try to achieve something that benefits all children. If you look at Africa as a continent, in 1996, 75,000 children were paralyzed by polio across every single country in Africa. And that was the year that Nelson Mandela stood up and said, "We're going to kick polio out of Africa," and basically launched this famous Kick Polio Out of Africa campaign. And every single community across Africa became involved and remains engaged. And that is why they managed to achieve eradication. It reemerged afterwards, and they're in the process of stopping this outbreak again. But it shows what can happen. I think delivering public health probably works best if you have public and civil society working closely together to kind of address communities' needs in that sense. And I think this is a good example of where this can be illustrated very, very nicely.
Are there any other
I hope that's
questions?
answered the question. Sorry.
I think I was just logged out, but maybe I can quick. There are a bunch of polio questions, Oliver, so maybe I can just pick one out while Fawaz is reconnecting. But
Oh,
thank you so
sure.
much
Thanks,
for,
Iris.
yeah, sure. Thanks for the presentation as well. And a lot of interest here. So here I see there's one question around ongoing conflicts and population displacement, and how does WHO adapt its vaccination strategies to ensure coverage in inaccessible or high-risk areas?
Sure. I mean, so our aim is to reach every single child with polio vaccine. That's the way to eradicate polio. If you reach every child, you vaccinate every child, polio virus has got nowhere to hide. And and there's many reasons why a child is not vaccinated. You might have maternal resistance to vaccination, you might have lack of infrastructure, inadequate vaccine supply, conflict, population movements, many, many different reasons. And poliovirus doesn't much care about any of those reasons. It just cares about finding the unvaccinated child, and it's very, very good at that. We have to care and we have to figure out, okay, what is actually going on? Why are we missing children in a given area? And then kind of address those reasons. There's not much point making assumptions. Okay, well, we're not reaching children because mothers don't want us to reach children. And then we spend a lot of time talking to mothers about the importance of vaccination, when the real problem is that you don't have a vaccine supply coming back behind you. So you need to figure out in a given area, what is the main challenge? And these challenges vary very greatly, in including across Nigeria, in Kano. It's a very densely populated urban area in Kano City. To map out exactly how many populations, children you have, to how to recruit enough vaccinators, order enough vaccine, that is a real challenge, particularly as demographic information in some areas is not as good a quality as it perhaps should be. In other areas in Borno, sadly we know that in the past, the Boko Haram was very active there. Getting access to that area is very difficult. So you adapt your strategies, for example, as populations move out of that area. You vaccinate them then. You vaccinate older age groups than you normally would. You also sample healthy individuals to test them for poliovirus. You do additional measures, or you reach, Fulani populations, which are moving across northern Nigeria. You set up vaccination posts at transit sites. So it kind of depends on what the prevailing situation is. And that is kind of then trying to figure out how to overcome. I think to we always have this double-edged sword because polio has been reduced by 99%. And if you take any other public health program in the world, COVID, measles, yellow fever, whatever, if you reduce it by 99%, you've achieved a tremendous success. But for us, we haven't achieved success. We've failed because our bar for success is so much higher. So to try to reach that last child and find that needle in the haystack is extremely challenging, particularly in some settings of the tribal areas of Pakistan that we're dealing with at the moment. But that is the goal at the moment, I suppose.
Thanks so much, Albert. A really interesting answer. And Fawaz or Oluwatosin, please jump in if we need to
All right,
stop. But
thank you,
otherwise,
Oliver, for that detailed
oh, great,
response.
perfect.
Oh yeah, okay. Thank you, Iris, for stepping in while I was trying to reconnect. There are two questions here that are very closely related. So I'll take them as one. The first question is, with vaccine-derived polio cases re-emerging in some regions, how is the World Health Organization balancing eradication efforts with maintaining public trust in vaccination program? And the second related question is, what can the WHO do as an independent organization to minimize conspiracy theories around vaccines?
So those are great questions, and it's a key challenge that we have. So the vaccine-derived cases that we're seeing, including at the moment in Nigeria, those are caused by the vaccine that we currently use. They emerge in areas where you have vaccination coverage gaps. It's a little bit complicated to explain, but basically the vaccine that we currently use is the oral polio vaccine. It contains a weakened live vaccine virus. It's weakened so that it doesn't cause paralysis, live that it induces an immune response in you. The problem, so that's the one that we use. In instances where you have vaccination coverage gaps, the vaccine virus can actually mutate from a weak virus to a strong virus and can actually cause outbreaks of the disease that it's meant to prevent. And that is what we're facing in some areas. And it's a huge problem for us. And a lot of people ask us, okay, number one, how do you stop such vaccine-derived viruses? Well, actually, the way you stop them is you stop them the way you would any other polio virus, by doing an outbreak response, by boosting your vaccination coverage, because if you vaccinate kids, they will be protected from any strain of polio virus, be it the wild one or a vaccine-derived one. So then these things die out. So the key to either wild or vaccine-derived is achieving high coverage. The problem, of course, is it's a little bit counterintuitive because this thing was caused by the vaccine in the first place. There's another vaccine that is available. It is called an inactivated vaccine. It's injectable, and it is a killed vaccine virus. And it is it does not have this risk of mutating. It does not have this risk of causing this outbreak. So a lot of people ask us, well, why don't you just use the inactivated polio vaccine? The problem with the inactivated polio vaccine is it's a great vaccine, but what it doesn't do is interrupt person-to-person spread. And what we mean by that is if I'm vaccinated with the inactivated polio vaccine, I'm protected from catching polio. I won't get the symptoms. But if I'm infected, I can still infect all of you. And of course, that doesn't help us if we're trying to eradicate polio. Whereas with the oral vaccine, not only am I protected, but if I'm vaccinated, I'm then no longer infectious. And so by doing these mass vaccination campaigns, by vaccinating all the kids, you're actually able to stop the spread of the virus. And so our aim is to eradicate polio as quickly as we can. And we can only do that with oral polio vaccine. But once we have achieved that, we need to stop using that particular vaccine and only use the inactivated polio vaccine, because otherwise we would continue to see outbreaks such as the one we're seeing in Nigeria. That's the strategy for all countries. Here in Switzerland, in my country, Germany, in the United States, Canada, all countries, they used oral polio vaccine in order to interrupt their indigenous transmission. Once they achieved that, they switched to the inactivated polio vaccine because of the risk of vaccine-derived polioviruses. So there's a reason why we have to do it this way. But it presents huge communication challenges, as you can imagine. But the key is, look, I think the point to make with these oral polio, these vaccine-derived ones, it's not actually a side effect of the vaccine itself. The kid who got the original dose of OPV, he's absolutely fine. He's got no symptoms whatsoever. He's just protected against polio. But this thing has over time emerged and changed genetically into something else. And that takes a long time to emerge. That takes about 12 months of genetic changes of the vaccine virus. So there's no, if you get the polio vaccine, you're not going to get this vaccine-derived polio virus. On the contrary, you'll be protected from it. And I think it's a complicated message. Our main message is, look, this thing is a polio virus. It paralyzes kids. You have to protect yourself. To do that, you need to be vaccinated. That's the overriding message, but sometimes it gets a little bit tricky. I don't know if that answer made any sense, but back over to you.
Oh yes, thank you very much, Oliver, for that answer. I think the answer was quite sufficient for both questions. We can only take one more question, unfortunately, as we're fast or we are almost out of time. So this question asks about what role does surveillance, AFP, and environmental surveillance play in detecting and preventing polio outbreaks?
Sure. And regarding the questions, just to say, if there are more questions in the chat, feel free to send them to Doreen, and Doreen, feel free to email them through, and I'll answer them in written format over the coming days. That's not a problem. AFP surveillance and environmental surveillance, without that, nothing would be possible in terms of polio eradication. It basically allows us to detect any poliovirus anywhere in the world within, a period of 2 weeks. And in a eradication effort, most diseases in a public health system, they get reported from district level to provincial level to national level on a quarterly, semi-annual basis. That helps ministries with planning, with budgeting. If we had to wait for 6 months to hear about a polio case, we would have massive epidemics on our hands. So we have devised an active disease surveillance network. We have staff all over the world. Literally, these are called informants. These are people who basically have direct contact to your communities. School teachers, religious leaders, imams, community leaders. We train them and say, look, any child that you see that displays these symptoms, you need to call us so that we can go in and collect stool samples. and be able to virologically confirm whether it's polio or not. So it is a huge network. It doesn't get talked about enough. You know, we talk a lot about immunizations, and I won't get too much into it, but it is an amazing network of a public health disease surveillance activity, and which actually detects many other diseases. You know, I remember that in 2014, during the Ebola outbreak in West Africa, there was a person with Ebola who traveled from Sierra Leone to Lagos in Nigeria and arrived there. And it was the polio surveillance officer in Lagos who detected this person, who detected that case and put this person into quarantine and organized contact tracing and essentially prevented Ebola from establishing a foothold in Nigeria. And Nigeria, we all know, is Africa's most populous country. It's a major travel hub. If Ebola had established a foothold there, this epidemic would have been even far worse than it already was. So this surveillance network is really something quite amazing that other disease areas benefit from as well. But that would be a whole other presentation, and I know we're short of time. But as I mentioned, you know, feel free to any other questions to email them through to us, and we will get back to you and respond to all of them. That's for sure. Back over to you.
Okay, thank you so much, Oliver, for your answers. They were very insightful. So up next, we will be, I don't know, is the Mentimeter available now so that we can just do that as a icebreaker before we wrap up the program? In the meantime, if it's not available, I'll be calling on Farida, the project director at Constable, to give us a closing address. Okay, so I think the Menti meters form have been sent to the group chat. So you can just click on it so that you can get access to the questions and answer them while the answers are being set up. So you can just check the chat box for the link to the questions and just click it so you can have access to the questions so you can answer them. So based on all of the sessions we have had so far, what is your new answer? I know that we wanted to test your knowledge prior to the start of the sessions, but we've received so much like insight and so much knowledge of what food does, how they work, and different answers for different questions. So now, how familiar do you think you are with the role and the mandate of the World Health Organization? You can be honest, and if you need more clarification, they're available. They have generously agreed to answer as many questions as possible in written form. So, yeah.
I just wanted to say, while people are doing this, that there were incredibly good questions. I've been trying to respond to as many as I can. There are some that are even too complex and very technical, but I'm really impressed with the incredible questions that were put in the Q&A. So thank you so much, and I really want to thank everybody for the participation, for being with us, and we try to do the best we can to provide information about the work that we do at WHO. And I just want to give a big thank you, because I also realize it's Ramadan and it's time for you to go to do your prayer time. So we hope we can release you very soon, and hope to see you all tomorrow to talk about youth engagement and how to get a job in global health, and what are the challenges actually to get there. Thank you. And thank you to the
Thank you, Jordan.
facilitators for doing a good job.
Thank so much for your time and your effort. Thank you so much for all the insights that you shared. So now we'll be displaying the responses. So I hope that everyone is participating. Okay, so we can have the responses shown now. So for the first question, it said, how familiar are, so many people are somewhat familiar. Well, like that's a big number. That's a big proportion of all of us. That's good. But, if you have any further questions or clarifications, you can ask Doreen or Iris. They'll be happy to answer, even Oliver too. So just send your questions here, or you can send it to any of the moderators, and then we'll, send it over for answers. Okay, so for the next question, which of these is something who does as part of the global health governance? Let's see what responses people are giving. Oh, I think there's like a technical issue. Oh, I think it's technical issue. So I think we might have to unfortunately stop here for today for the Mentimeter. But tomorrow it will be up, and we'll have fixed all the things of all the technical issues by tomorrow, by God's grace. So right now I'll be inviting Farida, the project coordinator at Cons Global, to give us a closing address so we can wrap up.
Thank you very
Farida, are you
much.
here?
Thank you for the invitation. Yes, I am. Thank you, everyone, for joining us today. On behalf of Queens Global, I would like to extend our heartfelt gratitude to all the speakers, particularly Ms. Doreen, Mr. Oliver, and Iris. It was a pleasure learning from you, and I'm sure we've all learned so much, and we are looking forward to more and more of similar opportunities to learn. Your contributions today have made today's session really valuable. We also want to thank all the participants for engaging with us, whether you joined via Zoom or YouTube live stream. A quick note, just as housekeeping, for tomorrow, the first 500 people to join would be able to stay in the Zoom. However, every other person will need to join through the live stream, but I don't want you to worry about your attendance, because we'll make sure to send in the attendance as well in both platforms. Thank you once again, everyone. I look forward to seeing you tomorrow. Have a lovely evening.
Thank you.
Thank you, Farida. Thank you, Doreen. Thank you to all the speakers who came. So, like you said, don't forget to fill in all the engagement forms that we sent. There are 3 of them, and they are necessary for your certificate. So please ensure that you check the chat box for the engagement forms and that you fill them out. And we'll see you by 6 p.m. tomorrow for day 2. Thank you for coming.
Thank
Bye,
you.
everyone.
Thank you.
In 1952, polio was everywhere. For years, this virus killed or paralyzed roughly 500,000 people annually, leaving survivors reliant on crutches, wheelchairs, and respirators. Yet just 10 years later, paralytic polio cases in the US dropped by 96%. So, what's the source of these recent spikes? And how can researchers fighting polio finally get rid of this deadly disease? To answer these questions, we first danger. Analysis occurring in less than 1% of cases. Why the region from airborne runs and once remain contagious for 3 to 6 weeks, spread